Hi, and welcome to the MedTech Insider, your inside look to all things med device. My name is Parker Snedden, and I'll be your host today. I have a very special guest with us today, all the way from Lexington, Kentucky, Dr. Mazhar Rasul. Dr. Rasul, thanks for being here with us today.
Well, thank you very much for having me over. First time in Kansas City and feel like I'm home.
We were just talking about that. You've never been to Kansas until just now.
Yep, this is the first time.
So, first reaction of how does it compare to Kentucky landscape-wise? It's not as pretty, right?
Definitely not.
Now, I know you've got an amazing farm at your house. So when you're comparing the farmland versus what you see in Kansas, it can't compare, right?
Yeah, no, I love Kentucky.
Yeah.
Love my farm. That's my hobby farm. So it's different, but I'm sure it has wonderful things. Spinal Simplicity's headquarters here, so had to be something.
Yeah, well, we're so glad you're here. Thank you for being here in Kansas City, sitting down with us, talking a little fun, but then also we'll have a lab this weekend, so you got a full weekend with us. So thanks for being here.
Absolutely, my pleasure.
Yeah, we were talking about just your passion for intervention and what made you move from more conservative management to thinking about some other interventions kind of down the road with SI joint fusion and posterior arthrodesis. So I'm going to start off the podcast by asking you, what made you passionate to move toward more interventions in that way?
Right, so been practicing pain management close to 20 years now. So there come a point where we were telling patients that have been in the practice for about 10 years now, and then injections slowly provided diminishing relief. And so kind of I hated to tell the patients that, we don't have anything else to offer to you. Or before throwing in the towel, we tried our level best. And I'm going to use this phrase very early in the interview because I use that every day. The eyes cannot see what the mind doesn't know. So about 4 or 5 years ago, started looking into what else is there that we can help our patients with. And with that quest in mind, seeking out what is there that other people are using. So started learning about sacroiliac joint fusion, basivertebral nerve ablation, multifidus nerve stimulation, intraspinous fusion devices, and slowly took a leap, did experiment, and it worked, picking on the right patients. That was the key. So that I think helped, and then slowly my partners started seeing it. So the whole team started seeing it. So now we are able to help our patients. Before throwing in the towel, we have much more to offer to our patients, not just offering the patient something more, something that is longer lasting. Here's a quote that my APP uses every day with all our new patients, or used to say with every patient, is we haven't cured a soul. Anybody who walks into the clinic, we have not cured them. And I can say that we are curing them now. We're providing them with much longer term relief. The longest relief we were providing with radiofrequencies was 6 to 9 months, maybe few patients with spinal cord stimulators, intrathecal pumps. But now with sacroiliac joint fusion, intraspinous fixation devices, basivertebral nerve ablation, multifidus stimulation, we are providing them with much long-term relief or permanent relief. So that makes me very happy because it makes my patients very happy.
Yeah, there's a lot of reasons I respect you, but one of the reasons I really respect you, Dr. Rasul, is that the way you answered that question is in a response to how you want to help your patients. And so it wasn't like you were seeking out interventions on your own siloed. It was more of, hey, I have patients that I know I can help with this. And so that mindset that you have, I think, is super unique, and I just respect you so much for it.
Well, thank you. I think it goes back to the philosophy of, and I would like to give credit to my teachers, and I cannot remember for the love of God who was that he used to say that if you put the patient's interest in mind, then everything else will fall in its place. So it's a huge maze every day between the economies of things we are doing and what is right, what is wrong. But if you just remove yourself away for 1 minute and then think about the patient, then everything falls in its place perfectly. Which device to use, which company to use. If you think the patient's, if it's going to help the patient, I'll use it, and everything else will fall in its place.
Yeah, I love that.
Yeah.
Patient first. I mean, that is one of our core values, and we love partnering and serving other physicians who think that way. And so I love that that's your mindset. It's so good. Okay, let's maybe get specifically into some of the technology that you've adopted. And I just want to talk about your journey with SI joint interventions. So you started, I imagine, with injections, and then what has your journey been like with SI joint interventions?
This is going to give away my age, right? So, so we were doing injections blindly at that time, and then I've seen fluoroscopy come into the pain clinic. So we were doing sacroiliac. So we were diagnosing the patients with sacroiliac joint dysfunction, and we were doing injections if they were helping. Then we slowly moved into doing lateral branch blocks and radiofrequency ablation. So we've done radiofrequency ablations with every single technique. You know, you've done bipolar, you've done thermal radiofrequency, or we used to have longer cannula with 50 millimeter active tip burns. And the best relief we've had was with cool radiofrequency, and I loved doing it and slowly got good at doing it. But then I had patients who would want bilateral cool radiofrequency done. It takes about an hour, hour and a half to do bilateral, and then it's not available in the private practices anymore. So I was really struggling with the patients who had good relief. We knew the etiology, we just couldn't provide long-term relief. And then we had some patients who we sent to the university hospitals. They got long construct SI fusions, not good results with it. But then I started hearing about my pain colleagues across the street. They were using allografts, and I talked to them, and they said they had good results with it. So I started looking at allograft-based posterior sacroiliac joint fusions for selected patients, which I had nothing else to offer after 2 or 3 months of relief. And I had good results with it. For about a year and a half, and then some patients started coming back, and then it didn't really work for some morbidly obese patients, that was my transition into looking into lateral approach to the sacroiliac joint, and I switched from the allograft to the metallic implant, and I think the implant that I'm using by Spinal Simplicity is truly transfixing and compressing the sacroiliac joint and has worked beautifully. So thinking about my patient has worked great for them. I'll continue to use it.
Yeah, and I think it kind of goes along to your mindset is like, what can I do maybe either differently or think in another way to be able to help patients? And obviously, the space technology is evolving fast, right? And so as these different implants come out from whatever company, you just have to be going, is that right for my patient or not? And so that's your mindset, isn't it?
Correct. And then, there are variables to the patient. Is the patient osteoporotic? Is the patient allergic to titanium? Is he morbidly obese? What is my comfort and skill level? And what is the practice environment I'm in? So if you match the skills of the provider with the setup they are in and what works for the patient, ultimately, again, going back to if it works for the patient, with the patient's best interest in mind, you can pick the right device for the patient.
That's such a good way of thinking about it. Actually, let's transition a little bit to, there's all kinds of therapies now, even not just for the SI joint, but for the lumbar spine in that area. And even thinking about, we were talking about this a little bit ago, even upstairs, like using different therapies in the same surgery setting, as you look at modic changes, as you look at the central canal, as you look at the neuroforamen narrowing. I mean, there's all kinds of pathologies as you try to help your patients. So how do you think through, gosh, which one should I choose first? Which one should I use? What's kind of your thinking in that, Dr. Rasul?
There's a litmus test kind of a question we ask the patient. So if the patient has equal leg pain and back pain, and you ask the patient, again, that's a hypothetical question, if we can take only one pain away, which one would you want us to take away? And the patient will be very clear. Even though he's saying 50-50, he'll say, take my back pain away or take my leg pain away. That kind of helps us move in the direction. If I see modic changes, my first thing is I want to go ahead and do the basivertebral nerve ablation. So again, searching for the truth, you have some of the best studies with 5-year data, patient outcome studies, and it's really binary. If you see modic changes and patient's clinical presentation is there, basivertebral nerve hits it out of the park every single time.
Yeah.
So that's a kind of a thought process as to what would you offer the patient is what would help the best. And I tell the residents every day, the patients don't come to us with one single problem. They come to us with 3 or 4 problems. It's our job to triage what's going to help them the most. And sometimes we're able to combine therapies. And so you really stack your relief and not really just touching them with a golden stick and everything is gone. So patient education is important. Building a great team is important, not just from a procedural or a therapy standpoint, but treating the patient from a biopsychosocial. So what we've talked about is biological. Patients also have psychosocial issues. So if your team member involves a good behavioral therapist, a psychologist, a dietitian, a physical therapist, all these things help, and it's a combined effort of the team that helps. So I think that's just the model we follow for our patients.
Yeah. No, it's so good because I imagine not very often a patient comes in with one area that is obviously some areas will have more pain than others, but oh, just my back hurts or just my legs hurt. I mean, there's going to be multiple areas of pain. And so it's great that you have multiple tools to be able to treat them in that way. So you mentioned teamwork and you talked about your APP. We didn't talk about this beforehand, but I'm just curious, as you guys work together and they're seeing the patient, you're seeing the patient, how do you guys work together to try to say, okay, what should we be doing for the patient? What should we be offering them?
Well, first of all, I'm very blessed to have a great team, and starting from our clinic managers to our APPs. So we've worked together for almost 18 years now, so we don't have to knock on each other's doors. We know what the other person is thinking. So one thing, again, okay, I'm using that term again, the eyes, the eyes cannot see what the mind doesn't know. So one thing we emphasize in our practice is education, educating the whole team. And I cannot tell you how it impacts the patients. What I know is what our physical therapist knows, what our PA knows. And once they see the patient, it is just crystal clear to them, like, this is what this patient needs. I'll give you a quick example. We did a little bit of education on lumbar spinal instabilities, degenerative instabilities, and very first patient we saw after that talk, my resident comes to me and says, Dr. Rasul, I see fluid in the facet joints. I said, bingo. Okay, so see, that's the benefit of seeing it. Once he saw it, he cannot unsee it. So that education is important. Teaching everybody in your team is important. So
yes, you're educated, the mind knew, saw the MRI, saw the fluid, and knew that this might be an indication of instability. And then you had something, to going back to your previous point, to be able to treat that patient now. Whereas before, I don't know what you would have done before, but now you have a tool in your toolbox to be able to help that patient.
Correct.
With Minuteman. So yeah, that's fantastic. Okay, right in the middle, we're going to do some fun. I purposely did not prepare you for this.
Okay.
Rapid fire questions. Okay, so we're going to do some rapid fire questions. Okay, so what's one thing patients would be surprised to learn about you?
That I have a tractor.
Why would that surprise them?
I don't know.
Yeah.
They probably don't see me as a farmer.
Yeah.
But I mean, if you can tell that I'm passionate about pain management, I'm almost as passionate about farming. Anything farming, I love it.
That's like my favorite thing about you.
Right.
It is surprising,
Right.
and you showed me some pictures of your farm, and it's
Right.
just beautiful.
Well,
It
thank
really
you.
is.
Thank you.
It's
I'm
a lot of
blessed.
fun.
Yes.
Mangoes, isn't that right? Is it mangoes?
Mangoes, I would
Yeah.
love to grow. I cannot
Yeah.
in Kentucky because of the weather, but
Yeah.
anything that weather allows, we're growing in Kentucky. Apples, peaches, pears, pawpaws, persimmons, figs, all kind of berries, vegetables.
I gotta eat some of this sometime. Come on,
Yeah.
next time you come to Kansas City, you gotta bring a basket. Okay,
All right,
that's
will do,
awesome. I
will
love
do.
it.
Yeah.
Okay, what is the favorite part of your workday that no one talks about, or just favorite part of your workday?
First hour of my work, I get a lot done. I guess I'm fresh in the morning and there's nobody there. I'm the first person in the clinic. Looking at the images myself. I pull up the MRIs of all the patients that are coming to the clinic. So that's a habit that I would say come from my anesthesia residency days, that you would pre-op your patients, you will go through their chart. So I look at all my patients' charts myself in the morning, and I go through their imaging. So I think that made the biggest difference in how I manage the patients, and I think it ultimately made the difference on how the patients get relief. I cannot emphasize this enough, is to us physicians, we should be looking at our images ourselves. Radiologists are doing a great job. They're not looking at it from our eyes. And once again, I'm thankful for the team, my hospital, the radiology team. They were able to install the same software that the radiologists have on their computers. So it makes it easy for me to look at the images. I would not be able to offer all these therapies to the patients if I wasn't looking at the images.
Yeah.
One recent thing that has happened is we have started ordering flexion extension films on almost every patient that's coming to the clinic.
Yeah. Why do you do that?
The static imaging were not giving us the true picture of the degenerative instability that we see on our patients, and my practice is fairly elderly patients. You know, they're old patients, and very commonly, you know, the injections we do, either it helps them or doesn't help them at all, and for a very short period of time, and then you're forced to look into, okay, I need to order some more studies. So we've made a habit of just getting, once again, the radiology team is very good. Even if they're in the waiting room, we tell them to go get it done, and as soon as they get it done, I can review it on my computer. So that's the benefit of having a good team. And I'll give a shout out to Dr. Deer. He says, show up and be nice. And that's what happens. If you show up to work and be nice to people, then other departments also work with you, and it ultimately translates into good care for the patients.
That's good. I mean, I think that's something for our work too. Show up and be
Right.
nice, and it
Right.
promotes great teamwork,
Right.
and the patients are going to be able to interact with you in a more comfortable way. And so that's great. I love that you start your day with image review, just kind of getting your day going. That's fantastic. Okay, one more fun question. What is your biggest pet peeve in the clinic?
Okay, so English is not my first language. What does pet peeve means?
Pet peeve. Okay, so something that bothers you, something that's just kind of an annoyance.
I'll have to give it a thought. Okay.
Yeah.
A lot of things bother me. What bothers me the most?
And it can even be just in your life in general. Maybe not just in the clinic, but what is that one thing you're like, oh, it just bugs me? Trying to get to know you better.
So what bugs me sometimes, I mean, it's just going to sound funny.
Yeah.
If my IMED consent is, if the computer software is not working,
Yeah.
or there's a bug in the system and I need to get this patient to the room and I cannot get the consent done, or somebody's not cooperating,
Yeah.
or they're not seeing things from my point of view, and so it kind of frustrates me. But if I take a break and then try to educate them, then they kind of see it.
Yeah. Yeah. We all have those things that just bug us. And so for
Right.
you, it's like if the software is supposed to work, just work. Let me get on with my day. I get it.
Right.
I get it. Yeah, that's good. Okay. Let's talk about the patient that we're kind of calling it the in-between patient, right? That you've maybe have had injections, RFA, maybe not a great surgical candidate, but now for you, you're thinking about them in a different way these days in the last 4 or 5 years. So what do you do with that patient? How do you think about them? What can you offer them? And how do you help?
So a great thing that happened was a discussion with our surgical colleagues, especially spine surgery colleagues, whether it's orthospine or neurospine or the surgeons who were doing SI fusions. So once again, showing up, being nice to them, and going back to my anesthesia days, I was in the operating room working along with the orthopedic surgeons and neurosurgeons. So they knew me at the same institution for the past 15 or 20 years. So it was very easy to carry on those conversations with those attendings and some of the younger residents. So the patients who fall through, or I call them, they disappear in the Bermuda Triangle, where we have exhausted our injections and we have discharged them from our clinic, and we say, well, maybe neurosurgery has something to offer, and they go to the neurosurgery. So either because of their comorbidities or the patient's fear of having an extensive surgery done, they don't get anything done. So they're limited to either conventional medical management or they're just going for intrathecal pumps. But I slowly started pushing the envelope with, well, I can really offer this patient a sacroiliac joint fusion myself, and safely without any complications. And that has been helping. And then so slowly inching towards some minimally invasive spine procedures that we as interventional pain physicians can offer the patient. And I understand that there's sometimes a little bit of a turf war, but we don't even think like that in terms of, well, if neurosurgery can offer minimally invasive spine surgery, then they can offer that. Somebody has to do it. There are very few of us who can do these procedures, and there are a lot of patients that need taken care of. So it doesn't really matter. If I have a surgical colleague who can help my patients, I'll be more than happy to help them. And if they can help guide me how to do this better, I'm all ears. I'm always in the learning mode. So I can always do things better. So that's where I think the patients who are falling into the crack, we need to help them by having better dialogue with our colleagues. Some of the institutions have started spine boards. So once a week, we come together for 2 hours. We talk about these patients. What do you think? An open decompression is going to work better? They say, yes, okay, fine, take this surgery. Comorbidities, no, we don't want to do open decompression for them. Fine, we can do a minimally invasive surgery for them. So,
yeah, no, I love that because it goes back to kind of your sentiment earlier of teamwork, right? Your APP, not only your internal staff, but you're talking to surgeons and looking at the patient workup and saying, okay, what's best for the patient here? And I think just an open dialogue with your surgeon colleagues is really important, it sounds like, to you. Yeah.
Yep.
Yeah, that's great. What would you say to a doc that might be considering a physician moving to maybe interspinous fixation, or they're moving to SI joint fusion? They haven't done any of those yet. So maybe someone who was in your shoes 4 or 5 years ago, and they're going, I don't know if I can do this, because I imagine at some point you were thinking that way. And then what would you say to them if they're entertaining it?
Right. So the first thing is to search for the truth. Okay. So go for the questions you have in the mind, go get them answered. Look at the studies, look at the evidence-based therapies that are out there. Look for the highest level of evidence that they're randomized controlled trials. Once you have done your own inference that this is a therapy that has been working, then talk to a colleague who has done them. I think that helped me the most, is just a collegial conversation with a physician in my shoes who have done them, and they can tell me the nitty-gritty. Well, this is the kind of complication you can get into. These are the side effects. And once you know those side effects, once you know this is the fear, then you can train yourself to overcome that fear. We as interventional pain physicians, we are quite capable of doing minimally invasive spine procedures. So once again, that collaboration with the physicians who are going to help you in the process. Um, Let somebody hold your hand. Um, Ask a colleague to step in, uh, be there for you when you do your first few cases. Have them review your charts. This is what I'm thinking. What are you thinking? Most of the times you're thinking you're on the right path, or they can tweak it. I would say find your fears. Once you have documented that this is the therapy that I want to do for my patients, then ask yourself, why am I not doing it?
Hmm.
Find that fear. What is that fear? And then overcome it. Get trained, get better, have somebody help you with your first 4 or 5 cases, and from there on, your patients will love you for doing it.
Yeah. Um, did you have any specific fears at the beginning?
So specific fear for me was drilling a hole in the bone with the Liberty implant, what I was considering. And quite rightly so, people had a lot of pain afterwards. So my training was anesthesia. We were not trained as an orthopedic physician or a neurosurgeon to take care of the patient's pain for 2 to 3 weeks post-operatively. But the patients who were saying they had a lot of pain in the first 10 days, at 2 or 3 month mark, they had their thumbs up. They see you, they are always happy to see you, and they're just so appreciative of what we did for them. So going back to, picking the right patient for the right therapy, it helps. So just the hump of acute pain post-operatively should not stop us from doing these therapies. And it's a normal process that's on par. People are going to have some pain. People get bigger surgeries, they have more pain than that. So we just have to acknowledge as an interventional pain physician that not everybody is going to come and get an epidural and go home and not complain of any pain. People are going to have some pain, but that's at par. And once you start doing them, you'll keep on tweaking your post-op pain regimen, including the medications you're giving them, whether you're giving them a cryotherapy unit or muscle relaxants or other things you're doing for them, and being as minimally invasive as possible. The post-operative pain decreases, your skills improve, post-operative pain decreases. But that should not stop anybody from doing widely established, safe, and efficacious therapy.
Yeah. So identify your fear, educate yourself, and then be confident that you can do it.
Yep.
Yeah. That's great.
Yep. Let somebody help you. Let somebody hold your hand. Don't be afraid to ask for help. Nobody thinks of you as a smaller person. I still, to this day, I'm never shy of asking, help me. What do you think I can do better here? Every single case I ask myself after doing the case, what could I have done better?
Constantly learning too.
Constantly learning, always in the learning mode.
Yeah. Who do you lean on these days, like to help you? Colleagues locally, at a society, a little bit of both?
Look, my residents, they are my biggest motivator. So they keep you on your edge, right? So you keep on learning new stuff. You keep on learning from them, actually. So one of my residents, Dr. Chris Mallard, he's now a program director at the University of Kentucky. So a resident that I trained now is a much better pain physician than I am, and I do not hesitate to call him and ask him for an opinion. Mm-hmm. So it doesn't matter who they are. I can approach any random person. I approach people at the meetings, at conferences. I know that's their niche. That's what they're doing. I remember I approached Dr. Douglas Beal about a basivertebral nerve ablation, a patient who had instrumentation, and he was very happy to help. So people really appreciate it when you ask questions, and I'll encourage anybody who wants to reach out to me. I'll be happy to lend my honest opinion.
Yeah, you're being taught and mentored, and you want to taught and mentor others.
Absolutely. Love it.
Yeah. So we've been talking about, as we end here, community a lot and teamwork. And I know you have a passion for Pakistan, the Middle East, and even just helping teach and educate over there, some of the things that you've learned. And so talk about that community and why you're passionate about bringing some maybe MIS therapies there, or at least educating them.
Right. So So goes back to the faith and the religion, and the fact that you have God consciousness, and um, education is considered an act of perpetual charity in my faith. Um, it grows exponentially. The rewards come back to you exponentially. If I am helping, I'm helping one patient. If I teach 10 residents a year or fellows a year, they go back out in the community, they help tens and hundreds of patients. So it the rewards, the prayers come back to you eventually. Um, and not just from the act of teaching, the inclination to give back to the lower middle income countries where I come from. I'm originally from Pakistan, and I keep thinking that I am very blessed. I am blessed to be collaborating with companies like Simplicity and be at the spearhead of technology for our patients here. And I would love to replicate that for not just in U.S. but beyond U.S. There are a lot of patients and very few doctors doing all these kind of procedures. I'd love to educate them all. I'd love to be able to provide these therapies globally, because there are patients suffering worldwide and they don't have any of that. And then so the first thing you do is to hang what's the lowest hanging fruit, and Middle East can be a hub of healthcare in that part of the world, and people from lower middle income countries, they go to Middle East before they would travel to US or UK for their healthcare needs. So we've collaborated some with physicians in UAE, and pretty soon they'll start doing some minimally invasive spine surgeries in Middle East. Think of Middle East, UAE as the center of US, and then they have all these neighboring countries like Saudi Arabia, Qatar, Kuwait, Lebanon, and so they all look at UAE. Cleveland Clinic is there. Mayo Clinic used to be there. Now it's another big 700-800 bed hospital. So they're very capable physicians. They're learning, and I think they'll be able to offer a lot of these MIS therapies in that part of the world.
Yeah, your mindset is clearly others focused, education, taking what you've learned and passing it along. And so all I can say is just thank you. Thank you for that mindset. Thank you for wanting to make the interventional spine space better. And thank you for being on our podcast today. Every time I'm with you, Dr. Rasul, I learn so much. And so really appreciate your time today. Thank you.
My pleasure.
Yeah, thanks very much. Thank you.
Thank you.
Yeah.